there's been a lot of repetition, and I'll try not to repeat. I'll call it reinforcement, which that's a learning technique. Okay, so this is where I'm at. I'm inside the Beltway in Bethesda. We have a hospital there called the Clinical Center. To reiterate, with Syringomyelia, it's about 1 per 10,000 people. So if you're in a town of 10,000 people, you're probably the one that has it. Usually presents between 20 and 50, but I think the pediatric neurosurgeons are taking some of the people before they're getting to adulthood now. Most of the patients have Chiari. Some have basilar invagination, as Dr. Menezes was talking about yesterday. Some have arachnoiditis, we just talked about that, and some have spinal tumors. You've seen this slide before, but let me just show you. You have the cyst in the spinal cord, and what it does, it affects what's called the gray matter, and those are the nerves, the central parts of the nerves, and the nerves go out to the arms. And so these nerves move the arm muscles. And so that's why you're weak with Syringomyelia when the Syrinx affects the gray matter. As the Syrinx gets larger, it affects these white matter tracts. That's when you get spasticity. That's when your legs get very stiff. And we'll be talking about the Syrinx distending the spinal cord. If the Syrinx is fat, it distends the spinal cord, and it has its effect. If it's just here, you don't really get the effect of the spinal cord being stretched, because this is after the person's died. But in life, the Syrinx is distended, and that pressure is thought to cause some of the effects of Syringomyelia, the long-term effects. So let me let you into the doctor's inner sanctum here. When we see somebody with Syringomyelia, we want to assess neurologic function. So we get a history. Are you describing pain, weakness, numbness, walking problems? And the time course is very important. Are they progressive symptoms or are they stable symptoms? If things aren't changing, we think, well, why change something? Because treatment really doesn't usually make things better. It just keeps things from getting worse. So if somebody's been stable for many years, usually we don't upset the apple cart. And then on the examination, we validate what's been told to us in symptoms, and we see, well, how weak are you? How much sensation have you lost, and where is it located? Are you unstable walking? What's your disability from this condition? And then we assess the anatomical structures. We do radiology. And people have shown you a lot of MRIs, but that's the next step. We want to look for anatomical deformities of the brain, such as hydrocephalus, those are the large ventricles, too much fluid, Chiari 1 malformation, narrowing of the spinal fluid pathways, Syringomyelia, spinal deformity, tethered cord. That handles most of the things. And we're really looking, if there is a Syrinx, does it distend the spinal cord? In other words, is the spinal cord fatter where the Syrinx is compared to adjacent parts of the spinal cord that don't have a Syrinx? And if you suspect that previous surgery or something else has made the spine weak, we do special studies of the spine to see if there's weakness and if a fusion needs to be done. All right, so this is what we look at with the MRI. Is there any space between, these are the tonsils, is there any space here? Is there a Syrinx? And how far down the tonsils are. But see, it really doesn't matter how far down they are. It's just this plugging, just like a cork in a bottle. If it's tight, that can have the effect if the tonsils are down 3 millimeters or if the tonsils are down 20 millimeters. It can have the same effect. All right, so who do we recommend treatment for? Patients with worsening signs and symptoms. Syrinxes that expand the spinal cord. Usually Syrinxes associated with a Chiari malformation and Syrinxes with a spinal lesion that obstructs the CSF pathways. Of course, if somebody's 70 years old and they've been stable for 40 years and they have a Chiari malformation, we probably wouldn't suggest surgery because they're pretty much telling us, hey, I've done this well for 40 years, it's probably not going to change. Now, non-surgical treatment is recommended for patients with lack of progression of Syringomyelia symptoms over a long period, Syrinxes that don't expand the spinal cord, and central Syrinxes with tapered ends, fusiform. Some people call these they don't even call them syrinxes, but they come from the radiologists with a diagnosis of syrinxes. So let's call them syrinxes. Other people would call them enlarged central canals. And any syrinx is not related to a condition that narrows CSF pathways. You do all the evaluation, there's a syrinx there, it doesn't really expand the spinal cord, but there's no block from a deformity and there's no Chiari malformation. Usually we don't do surgery on them. People have trouble understanding this. Most conditions, you break your leg, you have a cast, your fracture heals, you're okay. But in Syringomyelia, it's a little bit different because the injuries to the spinal cord. So your treatment's considered successful when symptoms and signs remain stable or improve, but usually incomplete, not completely, after starting treatment. But why do we do surgery then? Well, spinal cord damage from Syringomyelia is irreversible, so you want to do surgery as early as possible if you're going to do surgery to prevent further spinal cord damage and other medical problems. All right, so let's talk about failure. Well, failure is the opposite of success. So you do surgery and your neurologic deficits such as weakness and sensory loss become more severe after surgery. So that's the clinical part. And then the radiographic part is the syrinx is the same or greater size and it's still distended. The spinal cord is still expanded. All right, so if you have Chiari and Syringomyelia and you have successful surgery, your headaches are relieved. If you had unstable walking, that should be improved. If you had swallowing problems, that should be improved. If you had a central sleep apnea, that can be permanent, even with successful surgery, but it could improve. And for the Syringomyelia part of the Chiari and Syringomyelia, you should have stabilization or maybe mild improvement in signs and symptoms of spinal cord malfunction. The younger the patients are, the more likely they are to improve. The older, and on the other hand, the older they are, the less likely to improve. You'll have lots of other people talking. Those are just, some of these are just my reflections. So, okay, it's not gospel. Other people might have different opinions. I respect that. Okay, so on the MRI, the successful treatment is you want to create a space, you want to eliminate the syrinx, and the tonsils should go up a little bit. All right, well, what are treatment outcomes from this type? Most common type of Syringomyelia, the Chiari 1 malformation type Syringomyelia. Well, Dr. Iskander was here, and he reported that in his group, of pediatric patients, 84 to 86% of patients 1 year after surgery in the ASAP trial had smaller syrinxes, and their symptoms were better or unchanged. So the failure of the patients were worse clinically, and the syrinx was the same or wider, but they were worse clinically. Now then you have some uncertain people. They have stable symptoms, but the syrinx is unchanged by the treatment. So really, you wonder, well, how have they benefited from surgery? I mean, their symptoms are the same, and the syrinx hasn't been changed. Time will tell with this group. So we only have 1 year of follow-up. So let's look at the adults. So Dr. Batzdorf's involved here, and results have improved some since then, but generally 82% of the patients improved, 3-year follow-up. Logan Edwards, this is the Edwards in England, 82%. Bernard Williams and Seguros, 83%. So really the results are pretty similar for the largest studies. So it should be better than 80%, maybe less than 90%. So your failure rate would be approximately 15 to 20%. That would be the estimate, just from literature studies. Okay, so what's the usual response if you're going to have a good result from surgery? Well, you have the surgery, you have a syrinx, you have a Chiari malformation. Right after surgery, the syrinx is a little smaller. 3 months after surgery, you have a CSF space and your syrinx is gone. But it's variable. At about 3 months after surgery, about half the people will have the syrinx diameter, about half the size. But some people you have to follow out to 2 years. We had one person, I thought for sure the surgery had failed because the syrinx wasn't getting smaller, but he said, well, I feel better. I said, well, I don't know, maybe we should go back in. He said, I'm feeling better. So we kept following him, and eventually the syrinx became smaller. That gentleman had a little larger ventricles than the other people in this study, and I think that's what kept the syrinx from collapsing earlier. All right. Well, and some people, so that's the happy side. So let's go to the less happy side, the failures. This is a man from the Midwest, and he came and he had surgery, and over the year after surgery, he became worse, became weaker, lost sensation. And so this is the only study we could get from the outside hospital. Here's his Chiari malformation. You can see the top of the syrinx. Here he is 1 year after surgery, but he doesn't have the CSF space behind the tonsils, and his syrinx is still distended. And this is a problem with if you fail surgery. The process of syringomyelia just keeps acting, and it keeps acting on the center of the spinal cord, on those nerves in the center of the spinal cord that control your arms. And because of that, the nerves don't work, and the muscles don't get stimulated by the nerves, and you get what's called muscle atrophy. So that's what you see in syringomyelia. This is what you should see. Well, you shouldn't even see it. I mean, that would be mean to see it in a third world country, but this is what you should see in places where you have to wait too long and there isn't good surgical treatment. You shouldn't wait so long or be this affected. This is very upsetting to see somebody like this. But so you lose muscle, and then because the muscles that control hand movement are weak, you develop the claw deformity. And it used to be with descriptions of syringomyelia, this was a classic description, but we hardly ever see it anymore because people are treated earlier, before these kind of things develop. Okay, so with these 16 patients that we had in the study, 15 patients from elsewhere, one, mea culpa, one of them was my patients, so nobody's perfect. Some people have people that don't succeed with the first surgery. So anyways, here are the symptoms. Headache, more than half have headache, severe pain, weakness, loss of sensation, impaired ambulation, more than half. So compared to the pediatric group that Dr. Iskandar reported yesterday, these patients are much more severely affected because in that group, less than half had any neurologic deficit that could be validated, sensory or motor. So this is a much more severely affected group. So the good news is that in most of these, in this study, 15 out of 16 patients, we could establish a CSF space behind the spinal cord. Behind the cerebellar tonsils. Here's the cerebellar tonsils. So we created this space, which is great. Here's the syrinx. It went away, so we're patting ourselves on the back, fracturing our arms, patting ourselves on the back. But the bad news is that, see how thin the spinal cord is? The syrinx has injured the spinal cord at this point. And the hands aren't going to get better. That's the problem with syringomyelia. If you let it go too long, you lose function. So we certainly want to treat everybody before they get to that point. Here's another patient. She had surgery, has this nice little spinal fluid space, but the syrinx didn't get better, and her symptoms didn't resolve. They were actually getting worse. So we did flow studies. We saw that this space, this fluid, wasn't really attached to the rest of the spinal fluid space. So we reoperated, we created a space here, and you can see the syrinx got smaller. And her symptoms became stable. So, and this is for the group as a whole. With our operation, we want to remove enough bone so we can decompress. These are the cerebellar tonsils, so we can go out. So in six of the 16 patients, the bone removal was very narrow here, so it didn't go out to decompress the tonsils. And then the rest of the people had scarring inside the arachnoid from the previous surgery. So this is what we try to accomplish. Here's your Chiari to start with a Syrinx. What we want to do is we want to enlarge these spaces so there's normal cerebral spinal flow across the foramen magnum. And because this causes the Syrinx, this block, and there's lots of theories, but the block leads to the Syrinx, and if you relieve the block, the Syrinx goes away. So that's the objective. So if you fail surgery, you should have a re-exploration through the same incision. Try to accomplish the objective of the first surgery, which is to expand the space. And if you do that, then the Syrinx should go away. So it doesn't need to be permanent failure with this type of surgery if you do fail the surgery. Okay, but the downside is that even with quote-unquote successful surgery, the Syrinx going away, many of the patients have improved symptoms, especially with headache. But the other things that reflect spinal cord injury, they don't improve that much. They improve some, but they don't improve that much. So I said the Syrinxes in the group as a whole became smaller, but I had one patient who didn't respond to the surgery. And he required a shunt later, and he just had too much scarring at the foramen magnum for the operation, or for me at least, to open up the scar tissue at the foramen magnum. All right, let's move on to primary spinal syringomyelia. This is a man, he was a construction worker from New York. He came to see us, and he had a new wife. I don't want to go into it too much, but she didn't like it that he wasn't walking very well, and she thought that she didn't get the used car model. She wanted a new car. So basically, she was sort of upset that he wasn't walking a little better. So he comes up and he says, "Well, I'm getting ready to have my shunt. Do you have any other opinion?" I said, "Well, yeah. I mean, it's funny. Did they look at the whole scan? Because if you look at the scan, you see the Syrinx, but just at the end of the scan, you see this little cutout there, and that's right here. It's hard to see, but just right there." And I said, "Well, we should look into that." We got some scans around there, and it looked like there was compression there. And here on the axials, which are the cross-sectional, you can see the spinal cord is compressed a little bit, and its surgery ended up being a cyst. And so that's one of our patients. So that's what we want to see. We want to see focal problems. If you have a cyst and it's in a little area, we can take off a few lamina. Patients will do well. That'll be happy. But in this study as a whole, it was 36 patients, and we applied one treatment to all those patients. That was laminectomy and duroplasty. We weren't going in. We weren't going to do shunts. We were going to open up the CSF space, and we're going to without shunts. So we had 18 post-traumatic. We had some people after meningitis, surgical scarring. This was an old dye that's been taken off the market. No previous event that we could identify. 22 of the patients had previous surgery, and 11 had previous Syrinx surgery, and 43 patients, they were on the average 43 years of age, and we followed the patients in the study for 4.3 years. So you have to follow the patients because, well, this will come out later. So these patients, much more severely affected in general than the Chiari patients. Weakness, pain, spasticity. Many people had some problem with ambulation, much more paralysis. So here's a man, he was riding his motorcycle, then he became paraplegic, got his life back together. He was a professor at a Southern college, but he couldn't use the computer as well as he could because he developed this Syrinx. So he said, well, it's bad enough being paraplegic being in a wheelchair. Now I can't use my hands as well. So that's what happens with post-traumatic syringomyelia. You have a neurologic deficit, then it starts working its way up later. So what we did, and this was one of the successful treatments, was we decompressed here, and the Syrinx went away completely just by opening up the spinal fluid space. So that's the good news, but I'm talking about failure. So yeah, initially things looked good. 3 months after surgery, even people with sensory deficits, we had 3 of those patients it went away. Non-ambulatory, we had 1 person walking who wasn't walking before, but the bad thing is that once we followed them the whole length of the study, you could see that even some people who were walking at the time of surgery weren't walking 4 years later. And I'll go into that. So, we have some happy times. You can do the decompression here, and the Syrinx goes away, and the Syrinx here goes away, and we clean up the scarring that led to the block, which led to the Syringomyelia. So with Syringomyelia, you can have a block here at the foramen magnum and have a Syrinx, or you can have a block, that's the Chiari 1 type Syringomyelia, or you can have the primary spinal type of Syringomyelia that Dr. Batsdorf talked about, where the block in the spinal fluid flow is in the spinal canal. But both types, you need a block to cause Syringomyelia. All right, so we had 36 people, and if you look at studies, you might wonder, well, this is sort of boring. Everybody's like, oh, we have to take this person in this study, we take that person in this study, this was a mean. But really, as doctors, we work 1 patient at a time, and really, if it's you that has a good result, that's great. If it's you that has a bad result, that's devastating, So we had 28 patients who did well. We had 8 patients who, frankly, didn't do well, So then we always try to do better. So we look back, well, why didn't they do well? And so before surgery, Syrinxes were the same size in both groups. After surgery, patients who weren't doing well clinically, their Syrinxes were large. The people who were doing well, Syrinxes were small. The length of the surgery in the people who did worse was generally longer than before. We did this testing called pressure testing, and the people who had good transmission of pressure before surgery, they did well. The people who had really bad transmission of pressure before surgery, they did poorly. And the reason for that is the block was really tight. In other words, you couldn't get fluid past it, so it was much more of a challenge surgically to operate on those, to open it up, and to resolve the Syrinx. Okay, so we look back at our study some more and say, well, what was associated with success, what was associated with failure? The harder we worked, the worse we did. So it's like, and this just reflects youthful exuberance. I thought, well, if we worked a little harder, we took scar at many more levels, and these people who had very extensive scar, that we would do better. But really, the patients who did better, the patients who had Syrinxes that got smaller after surgery, had the more limited surgery. The other thing is, and I didn't update this slide to 36, but the patients who had a complete block, in other words, we put the myelogram in and it didn't get past where the area of scarring was, no dye got above that level, they did extremely poorly. They all got worse eventually. Whereas the patients who had a partial block or no block, they improved. So the myelogram is a very good way to assess patients as far as their prognosis. So our conclusions reflect Dr. Batsdorf's conclusions, but I think that, and a lot of people sort of came to this, but if you have focal arachnoiditis or trauma, you can usually open the spinal subarachnoid space, and this type of syringomyelia will go away. If you relieve the myelographic block, then that's associated with a good result. If you have extensive arachnoiditis, even doing multi-level laminectomies, even if the scans make it look like the scarring is somewhat limited, that will be ineffective at opening up the spinal subarachnoid space. And we've heard a lot of bad things about Syrinx shunting, but doing an operation that's not going to be effective just delays the process. So if someone isn't going to respond to laminectomy and neuroplasty, you should just go to a shunt. Hindsight is 20/20, you know. So it's so most people got better, but there were some failures, and so and now we know we can predict the failures, and we can direct the best treatments to certain types of patients. Okay, so the other ones are completed studies. And now this is a work in progress. So we have a natural history study. Why is this different from the other studies? Every study is a little bit different. You know, it's like a Buick or a Mercedes. I like a Mercedes. Or I like those Suburbans. I like Suburbans too. But anyways, I'm not looking for a car here. But I'm just saying every study is a little bit different. It's just like different models of cars. And people like different studies. Our study is different in that we don't operate on everybody. We operate on the people who are getting worse. So the other studies will tell you, studies will answer certain questions. Like if you have a study and everybody gets surgery, your answer will be not, hey, if I come in, how would I do with surgery? How would I do without surgery? You're not going to get that answer. You're going to get the answer, if I have surgery, I'm likely to get this result. That's the answer you'll get. Or if they compare two treatments, you'll say, well, I get this result with this treatment, this result with the other treatment, and then you can choose which one's better. But with this study, most of the people who are progressing will have surgery, but some won't. Okay, so we designed it for 5 years follow-up. We see patients every year. They have to have syringomyelia and or Chiari malformation, and we measure pain and function. Now that's the other thing with studies. How do you measure pain and function? Do the doctors assess the patients and send the evaluations into the database manager, or do the patients give how they're doing? You'll get vastly different results, as I found here. Okay, so here's our groups of patients. We have Chiari 1 without Syrinx, Chiari 1 with Syrinx, Syrinx without Chiari 1. So we have surgery, and then we have an observation group, and the observation group are people who either didn't want surgery or we suggested they not have surgery because they were stable. And we do all these functional tests. This is ambulation test, Karnofsky, and functional independence measure, and also the cognitive functional independence measure. So we want to see how well people ambulate, but this Karnofsky scale is very important. How much does the Chiari and Syringomyelia affect your function? And you know, before I started asking patients to fill these out, I thought, well, they're doing fine. You know, they look fine to me. They always smile at me. But when you ask them to fill it out, they'll say, well, yeah, I have some effort, but I have signs and symptoms, but you know, I'm unable to carry out normal activity or do active work. So many of the patients in our study have been fairly disabled. And then we ask patients about pain, which is very common in Syrinx patients. We ask them about their medications that they're taking. And we use standard measures. You know, we don't make these up. This is a standard McGill pain questionnaire. And we ask them about all the characteristics of their pain. So these were the patients. So the primary spinal syringomyelia, our surgical patients, the Karnofsky, 76 was the average, non-surgical about 80. That means normal activity with effort, some signs or symptoms. Chiari even lower, They were down, requires additional assistance, but cares for most of their needs. And Chiari 1 alone, without the Syrinx, they're doing a little bit better. So they're in this range. Then after surgery, when they fill out questionnaires, it's much different. It's better for me to say, are you doing better? They say, I'm doing better. I say, oh, great. Well, I made you better. That's fine. But they are better, but there's some better. They're not a lot better, a lot of them. So they have 10 pain, and it goes down to 7. 10 cramping pain, it goes down to 5. Now that's an improvement. If you have your study and you say, look, I'm going to declare victory if people are improved, that's good. But you really don't see everything. You don't see that people got better, but they're not perfect. And the same thing with functional measures. Here's people before and after surgery. Most of the things moved over, like dressing upper body. Now the person can dress the upper body. Bed to a chair, they can transfer better. Tub shower, so they're more independent, but still have some trouble walking. And some of the cognitive problems improved, but they're not improved to be completely independent. They're still like depending on their spouse to help them out. So they're better, but they're not perfect. So depending on the study, this study is telling us, hey, people are improved, but they're not normal, a lot of them. So then we looked at the people who had surgery and who were observed, but it's a 1-year follow-up, same as the ASAP study. And so the Chiari without Syrinx, this is the initial visit. This is when we saw them 1 year later. And so if they had surgery, most people improve. They're better at their later visit. If we observe them, they're usually the same. Okay, this is without surgery. With surgery, they're about the same. With observation, about the same. Syrinx without Chiari surgery. Surprisingly, some of these patients improve. Most of them stay the same. And Syrinx without Chiari, surprisingly, most of the patients get better. And why do they get better? Well, they think they have this horrible Syrinx and they're going to get worse. And they're reassured and they get a scan in a year and they say, well, your scan hasn't changed. And they feel better. So that's just a finding that was unexpected. So reassurance can make people feel better. So we looked at pain versus the size of the Syrinx. And so after a year, some of the Syrinxes became much smaller, surgical, particularly in the surgical group, that had absolutely no effect on the pain that patients had before surgery. So to conclude, all patients, at least in this natural history study, all patients with Syringomyelia and or Chiari had pain. Most had reduced quality of life. The Syringomyelia pain persisted over time and responded incompletely to surgical treatment. That's because the Syrinx caused irreversible damage to the spinal cord. Commonest problems in this patient group, the Chiari, Syringomyelia, and Chiari alone: headaches, pain primarily in the posterior neck and shoulder, weakness, sensory abnormalities, imbalance. And we really need, as the whole group knows, adjuvant non-surgical treatments to help with the residual pain and the disability, because surgery is not the whole answer. There's some value, though, to being seen by, I consider myself a specialist at this point. We can pretty much pick out who's going to need surgery and who didn't. And some people came in thinking they had suggestions for surgery from other people. And if you saw the Syrinxes that didn't distend the spinal cord, that had sharp ends, that were fusiform, as Dr. Batsdorf used that term, those people don't need surgery. But some of the Syrinxes were 5 or 6 millimeters, so they were a large variation of what you would call a central canal. So, but we followed them, and actually the people, as far as function and pain, or function, not necessarily pain, they improved over a year. So we could pick out the people who needed surgery, the people who didn't need surgery. All right, so let me get back to failure. That's my topic. It's sort of a sad topic. But so treatment success is more likely than failure, both for the Chiari and for the Syringomyelia alone, the primary spinal. But you have to frame success. Your success depends on how much you've been injured before you have the surgery, because the injury to the spinal cord by the Syrinx is generally permanent. All right. If you have Chiari 1 type Syringomyelia and you fail surgery, most of the time a second surgery can resolve the Syringomyelia, so you should have the surgery. If you have really bad arachnoiditis, you might fail the second surgery. Then you might have to go to shunts or something like that. With the primary spinal Syringomyelia, it depends. If you have extensive arachnoiditis, you probably should go to another procedure like a shunt. If it's still localized, the scarring, it's probably worth it to re-explore that too. And re-exploration means just going in through the old incision. So it's usually not as bad as the first surgery. So, all right, so a lot of that is my opinion. Hopefully other people agree, I don't know. But thank you.